This program is brought to you by Emory University.
But anyway, good morning and welcome to Cardiovascular Grand Rounds. This morning we have Wendy Book, who all of you know. Wendy is the director of our Adult Congenital Heart Center and has done an absolutely amazing job in building really one of the busiest adult congenital heart centers in the country. Wendy did her cardiology fellowship here and completed some interesting routes to get trained during her general adult cardiology fellowship training so that she could gain experience. It was really her own passion that drove this from day one, and she has been enormously successful, not only in terms of the size of the clinical operation, but also the educational component, the enthusiasm she generates among her colleagues, and also the growing research program that she's building within adult congenital. And I personally think it's the most complicated thing in cardiology. Apparently the adult cardiology boards agree, based on my scores when I recertified last year. And so I'm going to pay close attention as Wendy talks to us about VSDs.
Well, thank you for that very kind introduction. I'm going to do something a little different than I usually do, which is spend an entire hour talking about a simple defect, and that's because it's a common one. So hopefully your enthusiasm is high for this. I will say I'm an adult cardiologist, and therefore my bias is towards those who have survived into adulthood, and I view the world a little differently than my pediatric colleagues. Let's start with a little question. How many of you are really enthusiastic about this topic this morning? Oh my God, none? Okay. And those of you at home, glad you're on mute. Anybody think this doesn't apply to them, that it won't be on the boards? No. All right, and it will be on the boards. Chris, I'm going to have some echoes that probably will play better if we turn the lights down a little bit. So why do you need to know about this? Well, besides the fact that it makes up roughly 9% of the board exam now, congenital heart disease, there are now more adults than children with congenital heart. It seems like 30%, yeah. More adults than children with congenital heart defects. And we estimate currently 1.5 million as the adult prevalence in the United States. Their birth prevalence is stable. We have about 90% survival to adulthood, and this is going to grow at roughly 5% per year. In the state of Georgia, we have about 50 pediatric cardiologists caring for the kids, and there's 6 of us on the adult side now. We've come a long way in a half century ago, more than a half century ago. First blue baby operation was done at Hopkins, and open heart surgery for congenital heart disease really took off about a decade and a half later when the pump oxygenator was developed, making open heart surgery possible. So now these little kids who were born with even the most complex heart defects can grow up and survive to adulthood. Back in the 50s, even something as simple as a ventricular septal defect was fatal in many of the children. They would die from congestive heart failure if the defect did not close on its own or get smaller. If you go into a room of 100 people and look around, chances are one of them has a congenital heart defect, at least one. So you will see this, and I know you are already seeing this. We have about 9,000 patients in the Emory system with heart defects. Right now, the guidelines are based on complexity, and that complexity is defined in a mix of anatomic complexity and clinical complexity. So under the simple defects, those are simple anatomic defects, and ventricular septal defect falls under that. And complex end is some of the complex repairs for transposition in univentricular hearts, or Eisenmenger Syndrome, for instance, which I spelled wrong there, which is a complication of VSD. And you can see there are some VSDs that fall in that moderate complexity category, and those are patients that might have valve obstructions, infundibular stenosis, RVOT obstruction, and then the septal defects. The guidelines for congenital heart disease focus mainly on the type of care these patients should receive. And for those with a simple defect such as a VSD, recommendation is follow up with a cardiologist and one visit in their lifetime as an adult to an adult congenital center to ensure that they truly have a simple defect and are not dealing with any complications of either their initial repair or their unrepaired simple defect. Those that have moderate defects should touch base with their adult congenital center every 2 years, and those with more complex defects should have their care based in an adult congenital center on an annual or more frequent basis. The ventricular septal defects can be thought of in 4 very broad anatomic categories. I'm going to get back to number 1 last, the perimembranous defects. Typically you see those at approximately 10 o'clock on that peristernal short axis view on the echo. They're adjacent to the tricuspid and aortic valve, and the aortic valve forms the roof of the defect. The inlet or AV canal defects are adjacent to the mitral and tricuspid valves and are part of the AV canal defect. The muscular defects are in the ventricular septum. The subarterial defects sit in the vicinity of the aortic and pulmonary valve, and they can range in description and name from subarterial, supracrystal, subpulmonary, subaortic, doubly committed, just depending on their vicinity to the aortic or pulmonary valve. I'm going to focus on the first 2 because they're more likely to be seen with late complications and far more common. I'm going to start with some cases. In fact, this will all be cases. We don't have any randomized controlled trials in congenital heart disease to show you, so we'll start with some cases. This young woman was told, you have a small defect, no follow-up needed, so we're going to call her no follow-up needed. She comes in for a routine physical, feeling fine. She's active, but has never really been able to keep up with her peers, and on further questioning notices that for the past 5 years, she's had a decline in her exercise tolerance. She knows that she was diagnosed with a small VSD in childhood. She's had a murmur all of her life and had been told at the time that nothing needed to be done ever. That was her interpretation. On exam, her neck veins are not elevated, suggesting her no significant RV dysfunction. You know she has a VSD, so you think you're going to hear a murmur like this. Nice holosystolic murmur. But you listen and it sounds a little bit more like that, although it's hard to really tell the difference. So in the chart you say, well, it's probably a holosystolic murmur. I know she has a VSD. But it's very loud. She has a peristernal thrill. And her EKG is abnormal. And this is her EKG. And you can see on this EKG, she's got RV conduction issues and has right ventricular hypertrophy on the EKG. Well, a small perimembranous VSD that's doing fine should not have an abnormal EKG associated with it. So now you're curious, so you do an echo, right? Always do an echo. Some people do the echo first. The stethoscope is important, though, in all of these cases that I'm going to show you. And you see a TR jet measuring 6.9 meters per second. And based on some simple calculations, she is diagnosed with pulmonary hypertension. She's told that she can't become pregnant. She's engaged to be married. She's devastated and told she has a very life-threatening disease that will shorten her longevity. Does this make sense yet? Well, we estimate pulmonary pressures based on the TR jet velocity, right? The right atrial pressure. Do we really get a PA pressure there? We don't. We get an RV systolic pressure. So what we've estimated with that TR jet is the RV systolic pressure. And in this young woman who has a very loud murmur suggesting a significant pressure gradient somewhere in her heart, it's unlikely that that murmur was of tricuspid regurgitation. She does indeed have RVH on her echo, significant pressure overload, systolic and diastolic flattening of the septum, and that's seen in the 4-chamber view as well. And what she has is abnormal anomalous muscle bundles, dividing her right ventricle effectively into two chambers. So you can see that the effective outflow from the RV is very, very small due to these circumferential muscle bundles, and this is a complication of VSD. In childhood, it can occur even in those rarely that never had a VSD. The Doppler interrogation of this area shows a gradient of about 7 meters per second. What the TR jet was measuring was the pressure in this inflow chamber of the RV, and you've got a gradient into the outflow chamber. Her pulmonary pressures are indeed normal, and this is a very treatable problem. And somebody's not on mute. On this 3D echo, you can see basically what that looks like, that those anomalous muscle bundles are forming basically circumferential obstruction with a small little hole that all the output is going through. And in the OR, this is what you see in the right ventricle, this tiny little hole, these fibrous bands connecting and holding these muscle bundles in place. The surgeon divides those, takes them out, and the patient improves. So that's her pre-op echo. And post-op, you can see complete relief of the RVOT obstruction. Her symptoms resolve. Her echo normalizes. Her RVH regresses. A couple of years later, she became pregnant, had a successful pregnancy, and her long-term outcome is very, very good. You can see these on MRI. I can't always get the echo images you want, and MRI can show you that subpulmonary obstruction as well. Our second case is a 30-year-old with dyspnea on exertion. This patient had been diagnosed with the VSD in childhood, and closure had been discussed and, in fact, recommended. For a variety of reasons, it didn't happen. As an adult, he's had progressive dyspnea on exertion, never had normal exercise tolerance. He has an echo showing a high TR jet velocity and a VSD that's actually large, and is diagnosed with Eisenmenger Syndrome and sent to surgery to close the VSD. On exam, it's the same kind of situation. You think you should hear this holosystolic murmur. Instead, you hear more of a late peaking crescendo decrescendo murmur, but hard to tell the difference when they're that loud. Parasternal thrill. Parasternal thrill, and a murmur of this intensity would be very unusual in a patient with pulmonary hypertension. EKG is again abnormal. Similar to our last patient, there's RVH and RV conduction delay. And right atrial abnormality. Patient's already had surgery by the time he presents, and this is a dehyst VSD patch, which you can see here. Didn't get better after the surgery. And what this patient has is very similar to our first patient. This patient had a very large VSD, has the same anomalous muscle bundles, probably had these same anomalous muscle bundles in childhood, which is why he did not develop pulmonary hypertension. This has probably been present from very early on, causing RVOT obstruction and protecting the lungs from pulmonary overcirculation. So again, this is a fixable problem. Cardiac catheterization confirms the high pressure gradient across that area. This patient had had a pre-op cath, and got to be careful not to assume that the RV systolic pressure and the PA systolic are the same. So he, again, fixed, good outcome. This one, 30-year-old with dyspnea on exertion. They all sound the same, don't they? Promise you this one's different. So this one, on exam, has a holosystolic murmur at the left lower sternal border, a diastolic murmur at the upper left sternal border. And listening to this patient, the diastolic murmur sounds like AI, but over the pulmonary area. So you go, wonder why. And the holosystolic murmur is at the left lower sternal border, and you wonder, could that be tricuspid regurg? On exam, this patient has clear-cut clubbing and cyanosis of the digits. It's not subtle, as you can see in this picture. EKG looks similar to our other two patients, but the QRS is significantly wider. And you can see there's a large perimembranous VSD here in the peristernal short axis view. There is systolic and diastolic flattening of the intraventricular septum and severe RVH. There is no outflow obstruction to the pulmonary artery. There is, as you can see, a large defect adjacent to the aortic and tricuspid valves. And the TR jet velocity is 4.5 meters per second. So this is true Eisenmenger syndrome. That's what these patients look like in adulthood. This is a complication of large septal defects. You have increasing pulmonary vascular resistance with shunt reversal. The cyanosis is due to that shunt reversal going right to left instead of left to right. These patients in childhood may or may not have a history of congestive heart failure. They typically were born prior to the 70s when surgery became possible for most of these defects. Obviously, there is a survivor bias for those that have made it to adulthood. These patients are now in their 50s and 60s. We also see these patients come in from other countries where they don't have the opportunity to have surgery coming in at a younger age. These patients do benefit from pulmonary vasodilator therapy. Surgery is absolutely contraindicated once there's established Eisenmenger syndrome with a VSD. This is a retrospective study, but this is about as good as it gets in Eisenmenger research world. This is a study done in England. They looked at patients retrospectively who had been treated with pulmonary vasodilator therapy for Eisenmenger syndrome associated with a shunt, ASD, VSD, or ductus, and compared them to patients who had not been treated. At the time this was done, the guidelines recommended treatment of functional class 3-4 patients and no treatment of functional class 1-2 patients. So the treatment group was a sicker group at baseline because of those current guidelines at the time. This is mortality here on the y-axis, and you can see that the patients who were not treated, even though they were lower risk at baseline, had significantly higher mortality over the next 7 years than the patients who were treated. So this is circumstantial evidence that perhaps these therapies do work in these patients. BREATHE 5 was a randomized placebo-controlled trial of bosentan in Eisenmenger patients, and it definitely demonstrated a significant benefit in exercise tolerance and symptom score. We have a number of patients that we follow that I met in the 90s, some on the heart-lung transplant list. And when these therapies became available at the turn of the century, these patients got on them, and they are moving into their 60s today without transplant. They do work. They need to be monitored carefully, very expensive, but these patients can benefit significantly. Our next case is a pregnant woman. She is completely asymptomatic and comes for a second opinion. She's been advised to terminate her pregnancy. She's upset about that. You listen to her, and her neck veins aren't elevated. She really looks good. She's not cyanotic, no clubbing. And you do hear that classic VSD holosystolic murmur when you listen to her. And because you've got a really good stethoscope, you actually can hear a bit of the second heart sound too. Her EKG is entirely normal, and she was told she has pulmonary hypertension and must terminate this pregnancy. So something, again, doesn't feel right. We've got a loud murmur, we've got a normal EKG, and no signs on exam that this patient has significant heart disease. The TR jet is estimating a RV pressure of 140 and 5.9 meters per second. But this isn't going to play. The others all played. But when you look at her echo, I'll describe it to you. She has no flattening of the intraventricular septum at all, none. It's perfectly round through systole and diastole. It looks like a completely normal heart. She's got a normal EKG, an exam that's unimpressive other than a loud holosystolic murmur, and an echo that doesn't suggest any signs of RV pressure load. So what's going on here? So we know it's not going to be pulmonary hypertension. We know it's not going to be a double chamber RV. She's lacking all the features of that. Pulmonary acceleration time is normal, just to double check on that. No pulmonary hypertension piece. There's no RVOT obstruction, no pulmonary stenosis in the branches, nothing to suggest obstruction. So in this patient, she has a small perimembranous VSD, and the jet is going up underneath the septal leaflet of the tricuspid valve. And this isn't completely uncommon. Sometimes it splits. One goes under the valve, one goes into the RV. And if you catch this jet, the part of the jet that goes up under the tricuspid valve back into the right atrium, you can be Dopplering where you would normally get your TR jet and get this instead and think that you have elevated RV pressure. So in this particular case, this is not the TR jet, it's the VSD jet. So if we plug that into our modified Bernoulli equation and add the RA pressure, what we're really estimating at the end of the day in this patient is her LV systolic pressure. So we would estimate that her LV systolic pressure is normal. So she was told she did not need to terminate the pregnancy, and in fact she did not need any surgery for this, and is being monitored. The last case I'm going to show you, and you know I'm not going to show you anyone who doesn't need anything done, right? Because that would be boring. So the next patient is acutely ill, and she was transferred from another facility. She had known she had a small VSD diagnosed in childhood, had been told nothing needed to be done. In fact, was told that it was getting smaller. At the time she left pediatric care. She's now 20 years out of pediatric care, but this had been getting smaller, and she didn't need to worry about it. About a month ago, she really became quite short of breath, fairly abruptly, had developed pulmonary congestion, pulmonary edema, heart failure, left ventricle was dilated, and on transfer was very ill-appearing, tachycardic, neck veins remarkably elevated. She had a thrill that was palpable throughout the left precordium, very unusual exam in an adult to have a thrill that's that readily palpable. She had a grade 6 systolic murmur, readily audible, and also had a continuous murmur in the background behind that. And that might sound something like this. So that's an important clue. VSDs don't make that sound in general. And again, the stethoscope can sometimes help you interpret your imaging studies. Not to sound old-fashioned or anything, but her EKG really wasn't terribly impressive. She's definitely got some abnormalities there. She's got a left atrial abnormality and some conduction delays, but certainly it doesn't look like someone who's had long-standing issues. On the parasternal short axis view, you're going to see the right coronary cusp right here prolapsing into the defect. And in the four-chamber view, you can see the left atrium is significantly enlarged, and the left ventricle is enlarged with normal systolic function, hyperdynamic state. So put that together with her exam, and this woman has high output heart failure. So why does she have that? What happened? Something happened a month ago that got us into trouble. You Doppler across the mitral valve just to confirm your suspicion, and the mitral valve is structurally normal. There's no anatomic mitral stenosis, and she's got very high velocities across her mitral valve due to very high flow. So this suggests a torrential shunt, high output heart failure, high velocity across the mitral valve, dilated left atrium, left ventricle, acutely ill patient. And this is that same parasternal long axis view, and that's the right coronary cusp, and you can see there's flow going from the aorta into the right ventricular outflow tract. So how is it getting there? This is Doppler through that same area. You can pick out the VSD jet. And I want to thank Sandra and Alicia for all of these images, by the way. They're absolutely spectacular. So careful Doppler interrogation, you can see the VSD jet, and in the background you've got your diastolic flow from your aorta. And you can see here you've got continuous flow in the RV outflow tract, and this is flow communicating through one of those supercritical VSDs from the aorta. And let's see if I can point this out here, because this is in this subcostal short axis view. At 2 o'clock, you can see this bulging. That's the right coronary cusp. It's bulging, and there is a hole in it. And there's flow from the aorta through the coronary cusp, through the supracrystal defect, into the RV outflow tract. So this woman has developed what physiologically is behaving like a sinus of Valsalva aneurysm that's ruptured. The same physiology through this perforated cusp, and we'll go over how that happens in the first place. And this is looking in at it from the other side. You can see the defect in the cusp, the hole in the cusp through that. So this kind of thing happens more commonly with those subarterial or supracrystal defects, which is why you need to know about them, even though they're less common. They're more commonly lead to trouble with the aortic valve. These defects, and this can happen with the perimembranous defects as well, just less commonly. The aortic cusp, almost always the right coronary cusp, gets sucked in through the defect. Over time, you have elongation of the sinus, thinning of the sinus and the cusp. As these get sucked in through this defect, they can cause RV outflow tract obstruction. They can cause weakening of the wall of the sinus and the cusp. And as they enlarge, they can actually close the defect and give the appearance that it's getting smaller over time. In comparison to the perimembranous defect, those subarterial defects are going to be crescent-shaped, and that right coronary cusp is forming the roof of it. And they're typically much larger than they appear on echo because the cusp is partially obstructing it. If these are fixed early, the aortic valve does not require replacement and typically can just be supported. So you've got this problem here where the annulus of the aortic valve lacks support because there's a hole, and you've got elongation of the sinus and the cusp, thinning it, pulling it through the defect. And over time, as in this patient, those can rupture acutely and have a very dramatic presentation. The supracrystal defects, those subarterial defects, when you see them, if there's AI or if there's distortion of the cusp, in general, those should be sent to surgery. They could be asymptomatic, it might look tiny, but if there's evidence that that right coronary cusp is in the defect and being distorted by that defect, those patients need surgery before they get into crisis and before they have damage to their aortic valve. The incidence of aortic problems with that particular type of defect is over 70%. With rare exception, when we see those, and those are going to be at 2 o'clock on your parasternal short axis view right between the aortic and pulmonary valve, we send those patients to surgery with rare exception. Much more common in the Asian population. And this is just another diagram, again showing just how distorted this cusp can be, how the aortic sinus is actually distorted and elongated as well as the cusp. And you can imagine that you could easily have a problem with the valve. Typically, the AI jet, before it ruptures, will typically go in the opposite direction. And I'll show you a picture of that. This is a patient who does not have a ruptured defect. And you can see flow across the VSD here, LV, aorta, LA, mitral valve. And this jet coming down at 6 o'clock is the AI jet going in the opposite direction of that leaflet. And you can see in the 2D echo here without the color Doppler, you can see the thinning and distortion of the right coronary cusp as it's pulled into the defect. On the parasternal short axis view, this is where those defects sit. Again, you're losing support for the aortic valve and the right coronary cusp, aortic annulus, so that's why these cause so much trouble over time. And then this is your AI jet going in the opposite direction as that right coronary leaflet is sucked into the defect. And you could imagine it in the OR that this particular defect might actually be much larger than it appears by color Doppler as that leaflet closes it. And this is again a view from the RV side in 3D, and just showing you how that coronary cusp is prolapsing through the VSD. We had one patient here actually had a RV infarction from kinking of the right coronary artery related to something like this. All right, so I promised I wouldn't bore you all too long, so we can kind of wind down here. The small VSD, well, it sounds simple. In fact, it is listed as a simple defect, and we are told that these patients do well long-term, and many of them do. When you look at the late complications of a small VSD, about 25% of people eventually have a problem as an adult. So 1 in 4 will eventually have an indication for surgery as an adult, and that's why it's critical to follow these patients, to understand what to look for on the echo, what are the clues on the physical exam that tell you that something is wrong and that the patient needs attention, what are those clues on the EKG. Small VSD does not cause RVH unless there is RVOT obstruction or pulmonary hypertension. They should not cause AI. If they do, the defect is probably creating some suction on that aortic valve and needs to be repaired. Incidence of AI in the adult population, roughly 6 to 10% late. Endocarditis is a problem. I'll show you a picture of that. Heart failure in the adult population is pretty uncommon, very common presentation in the pediatric world. They have pulmonary overcirculation like the patient I showed you with that ruptured right coronary cusp defect, and they present with high output heart failure as babies. In the pediatric world, they take them to surgery and close the defect. To have heart failure as an adult is really unusual unless there's some mechanical process that increases that shunt over time. We do see some that develop left atrial enlargement, left ventricular enlargement. We have seen some women with small defects who become pregnant and develop heart failure after pregnancy from a high output state. So there are some, and those ought to be closed. Double chamber RV, the first 2 cases I showed you, is thought to be a very rare complication of small VSDs. We operate on probably 2 to 3 a year. It is not that rare. In fact, it's just as common as some of the other complications that occur with these small VSDs. So always keep that in the back of your mind when you see that RVH and that high TR jet with a really prominent murmur, parasternal thrill. Be thinking double chamber RV first. This is endocarditis at a VSD. You can see there's a vegetation that is originating probably from either the leaflet or the defect itself. And this, once this occurs, this is an indication for surgery to close the defect. And I'll just bring this up once more. A high TR jet velocity in an adult patient with a VSD that's not cyanotic and doesn't have clubbing is highly unlikely to be pulmonary hypertension. It's much more likely to be RVOT obstruction regardless of the size of the defect. Look for that RVOT obstruction, look for those muscle bundles. If you've got a loud murmur, parasternal thrill, again, PH becomes unlikely. And double chamber RV is a progressive problem. These patients develop increasing obstruction over time due to increasing RV hypertrophy and hypertrophy of those muscle bundles. And the majority of them do need surgery when this is diagnosed. Very treatable problem. They can do well long term, but very easy to miss. Aortic regurgitation can occur due to mechanical forces on that cusp. The cusp normally rests on the ventricular septum. If part of it, the annulus is part of that is missing, you don't have support for the sinus and the annulus. You can get suction of the cusp through the defect, elongation of the leaflets, and eventual destruction of the aortic valve. So if the patient has cusp prolapse that's obvious on echo, has AI that's eccentric, even without obvious prolapse, think about whether or not they have an indication for surgery if this is secondary to the VSD. Patients with that subarterial, supracrystal, subpulmonary, subaortic, outlet VSD, whatever you want to call it, anything in that category that's at that 1 to 2 o'clock spectrum on your parasternal short axis view with AI equals surgery unless there's a good reason not to operate on that patient. And that's to avoid the catastrophe I showed you in that young lady. And she's fine, by the way. One more thing about those subarterial defects. As far as recurrence goes after surgery, those are more likely to have recurrence and patch dehiscence than some of the other defects, just related to lack of place to sew that patch on. So they need long-term follow-up and can have patch dehiscence after surgery. So in summary, the indications for surgery in adults would be a significant shunt in the absence of pulmonary vascular resistance, and the definition of a significant shunt is one that's more likely to cause problems than the surgery is, a 1.5 to 1 currently. They should not have elevated pulmonary vascular resistance. Patients who have increased risk for operative complications, that threshold would move up to 2. Patients with double chamber RV, any kind of RVOT obstruction in the setting of a VSD or a prior VSD that closed spontaneously likely will need surgery. 1 episode of endocarditis is enough to close that defect. And patients with a small VSD who have an enlarging LV need surgery, and the other indications, as I showed you for the subarterial defects with AI. So I'm going to end there. They leave you with this thought. The main thing you need to know about congenital heart disease is really all about knowing where to look, and you will find what you're looking for. And I'd be happy to take any questions.
Thanks, Wendy. Appreciate that. That's a great talk. I'll start you out with one. So with the Eisenmenger's patients, which pharmacologic approach do you prefer for the pulmonary to reduce pulmonary vascular resistance? You have a couple of options there. Any difference in those in terms of efficacy?
The only one that's been studied currently is bosentan triclear, which is ETA, non-selective ETA receptor antagonist, and that's our first choice for these patients. There are several others on the market. Ambrisentan, which is under the brand name Letairis, is on the market, and macitentan is being studied in Eisenmenger Syndrome, which is a long-acting version, basically, of the bosentan, similar class. We typically go to that bosentan first in that class. Sometimes the insurance company dictates otherwise. We have seen anecdotally more heart failure issues with the Letairis, which is a selective ETA receptor antagonist, but it's also a good choice. The PDE5 inhibitors, tadalafil and sildenafil, are on the market and not approved for Eisenmenger syndrome, and I would not typically go to those as first-line therapy unless the patient has a contraindication or an insurance issue with the other medications. The prostanoids we use as third-line therapy typically in these patients. The traditional route in the past has been intravenous. We've avoided that in the Eisenmenger syndrome patients, if at all possible, due to the risk of paradoxical emboli in these patients and the risk of infection and endocarditis, brain abscess, in cyanotic patients. So we've really avoided those. They do come in an inhaled version now, a sub-Q version, and now an oral therapy that just was approved this summer. All of those are limited by side effects, but are very reasonable third-line choices.
All right, great. We're going to open it to questions here, and then people remotely, you can unmute your mic and ask a question now or use the text box. We have some here. Please use the mic.
My question is about people who had successful repairs as a kid. Every so often we're asked to put an ICD in someone with a failing left ventricle that had a VSD patch. And my question is, how common is negative? Should we be thinking of these patches in the left ventricle as an infarct? How common is it for them a decade later to have a failing left ventricle after this patch?
Good question. I think it depends somewhat on the era that they were repaired in. So the kids who were repaired later in the earlier surgical eras, the typical process was to band the pulmonary artery when they developed heart failure as a baby, because they couldn't operate on the tiny babies, and then repair the VSD later. And I think those in that earlier generation are more likely to develop heart failure than those who are repaired today with primary repair at the onset of problems. The arrhythmia question with the patch, and VT is a late complication, as you know, some of these patients who've had a repair. It's not common, but it does happen. And heart failure in these patients, if it's related to the whole childhood process, and this is just anecdotally here now, it seems to progress more slowly, if you will. It seems to be more stable than patients who acquire heart failure later in life for other reasons. Just an observation. Some of it's related to the ischemic insult at the time of the pump run as a kid.
There we go. Wendy, with a moderate shunt, you implied that all those patients, or many of them, will develop Eisenmenger syndrome if not closed or large shunt. Is there any way that you can figure out, because not all do, is there any way prospectively at this point that you can say they will or will not get Eisenmengers?
If they're an adult if they've already made it to adulthood with a moderate shunt, it's highly unlikely they will develop Eisenmenger syndrome. You probably count on one hand the number that would happen to. In kids, much more common to develop Eisenmenger syndrome, and typically those that are going to have it by the time they hit an adult practice.
And is there any way to figure that out at the front end as who will and who will not get it, even as a child?
No good way that I know of to figure out who will and who won't, because they're all closed as kids now. They don't leave it to chance with the kids.
Thanks for a great talk. There are now several reports from in the literature of patients who have reached stage D heart failure, and they have what we previously thought was fixed pulmonary hypertension. But after, say, a 6-month therapy with a left ventricular assist device, in some of them, pulmonary hypertension has been reversed, and some of them actually became eligible for heart transplantation. Now, obviously, the situation is entirely different in patients with Eisenmenger, but are you aware of any attempts like to give a honeymoon to the right ventricle combined with surgery to see whether the right ventricle, whether you can reverse partially the fixed pulmonary hypertension, or in general use an assist device as a means to bridge these patients, at least for a while, as an experimental therapy?
So bridge them with the assist device?
So use an assist device to give honeymoon to the right ventricle in the hope that pulmonary hypertension is less fixed than we previously thought.
In the patients with LV failure?
No, in patients who
with
are not
VSD?
eligible for surgery because we think the RV is going to shut down right away. So are you aware of any attempts to support the right ventricle mechanically, to give it honeymoon as an experimental option?
Trying to understand the question. So with Eisenmenger syndrome, the left ventricle by definition is almost always normal. So they have normal wedge pressure, so supporting the LV, not necessary. They typically don't develop RV failure because of the shunt. So they behave very differently than the IPH patients who develop right heart failure and die of right heart failure. The Eisenmenger syndrome patients can augment their cardiac output by increasing their right to left shunt so they become more cyanotic, but they can sustain their circulation. And in fact, there's, I don't think Bacillus is here today, but there's some interest in Peter, you probably know about this, in an interventional way, basically creating a ductus in those IPH patients to offload their circulation in that way, so that assist device then, again, probably doesn't play any role. I don't know that you can overcome that resistance, honestly, in these patients who truly have that fixed pulmonary hypertension. The reversibility question and whether or not you can close some of these patients who fall in that gray zone is a great topic of debate. If you come to our Wednesday night conference, you can hear a heated debate any day, any time, any year. And there's papers on both sides of that argument that say you can close them, you can't close them. The most recent one suggested actually the outcomes are not that great long term if you close the defects in these patients who fall outside of those clear guidelines for closure. I don't think that answered your question, but
Okay, well, Wendy, thanks for a fantastic talk. We thank you again, and join us next week. Andy Smith is our speaker next Monday. Thanks so much.
Thank you.
The preceding program is copyrighted by Emory University.